Hello, everyone. Thank you for tuning into the webinar series, the Med Safety Exchange, a joint venture by the Institute for Safe Medication Practices Canada, SNP Canada, and the Canadian Patient Safety Institute, CPSI. So just a few housekeeping items. This webinar will be recorded so that it's available to those who couldn't make it at this time. We have all the lines muted, and we encourage any questions or comments to be typed to us in the Q&A box, and we'll read them out loud at the end of the webinar during the discussion period. I'd now like to introduce SNP Canada's CEO, David Yu.
Thank you, Ambika, and welcome to our second monthly webinar program, and thank you also for the presenter who are willing to share their learning. And for those who didn't attend our first webinar program last month, I would take maybe a minute to provide you some background information how this program, came about. And back in 2014, when we have the Medication Safety Summit, co-hosted with CPSI, we identified some of the key action plan to move medication safety forward. And so in 2015, CIHI and ISMP actually worked and developed a white paper identifying different incidents, medication incidents, data source, and also try to find out the gaps of where the learning might be missing. And so the second phase of that program or the initiative was to have convene a national expert panel to develop strategies, how to meet the goal of, more effective learning to be shared, across Canada. And actually, one of your speakers, Dr. Matthew Bo from Nova Scotia was also sitting on our panel. And so we decided that perhaps taking a page from UK, who the folks there running a monthly webinar program, participated by all the trusted hospital in United Kingdom, and that they find to be very successful. And so we try to, adopt that and then come up with a program like that. And thanks for CPSI for continuing supporting the program, and also thank you for the presenter across Canada and the people who attended this monthly webinar program. So I'm passing on back to Ambika.
Thanks, David. So I'm just going to go through today's overview. Every webinar will have roughly the same structure, but with different content. So for this webinar, we'll have 2 med incident analyses, remote prescribing of a chemotherapeutic agent, and a case from a medical examiner, followed by the observatory for a med safety update, and then we'll finish up with a discussion period where we read out your comments and allow the speakers to elaborate. Anonymity is a choice for all those involved in the webinar, so I'll only introduce speakers briefly, and they can choose to share as much or as little as they'd like about themselves and or their practice site. I'd like to invite the first speaker to discuss an incident analysis involving the remote prescribing of a chemotherapeutic agent.
And allowing us and our experience with this medication incident. So just to give a bit of background, electronic medical record adoption and use in Canada has dramatically increased over the past few years. And in Ontario alone, there has been a 13% growth from 2012 to 2016. And EMRs do allow multiple users to access and make changes to patients' treatment plans. And while this can help improve coordination of care, it, however, can pose a safety risk. And different practitioners may use EMR functions differently, leading to misinterpretation by other healthcare providers. So in our case, I'll give you a little bit of further background. We have the Mosaic EMR, which we use in our cancer center. And we've had that program in place since 2013. At the time that we transitioned to the electronic medical record, the transition was dramatic. We went from a completely paper record to a completely electronic record overnight. So essentially, on a Friday, we were using paper, and on a Monday, we went to a completely electronic medical record. It was decided not to use a phased approach because the thought was that, you know, even to this day, we may not be fully electronic. So they went with the all-or-nothing approach. At the time, Citrix access was provided for all physicians. Citrix access had been available to physicians in our current paper system as well, because the hospital where we work also uses Meditech, and it allowed physicians to e-sign documents and review reports. So they were already used to Citrix and using Citrix. We did consider a lot of workflow changes, and what's important to highlight in this incident is while we tried to consider everything, there was probably potentially things that we didn't consider that could happen that led to this incident. So the patient in question was a 69-year-old patient with multiple myeloma. He did have a history of other comorbidities. He was on Thyroid chemotherapy, and he had recently been admitted to the hospital for a possible lung infection, and he had been treated with antibiotics. He had been admitted to the hospital, I think, more than once with lung complications. We weren't sure if it was related to the treatment or if it was pre-existing, but he did have some pre-existing lung comorbidities. So at the Cancer Center in the Mosaic system, when a patient is started on chemotherapy, we have electronic care plans. So the program automatically sets up multiple cycles of chemotherapy based on the QBP through Cancer Care Ontario to allow all the cycles to be populated into the patient's care plan. The orders themselves are amber if they're unapproved. So it populates an entire care plan of unapproved orders, and the physician is required to approve them when they deem the patient fit for treatment when they come for assessment. So the orders turn blue if they're approved, and they're mauve if they're approved but have been modified. So if the patient has required a dose reduction or such, then the order shows up purple. And that does alert the pharmacy staff and the nursing staff to the fact that it's a change from the original care plan. It is possible to place the chemotherapy on hold. There is a hold function in the electronic medical record, and physicians are allowed to place chemotherapy orders on hold and release it. And we do have some special considerations where pharmacists in our program are allowed to do the same. There were 2 physicians that were involved in this particular incident, and the primary physician for the patient was at a remote site. So in our region, we have remote chemotherapy sites, and physicians often visit those sites to run clinics, and this physician was off-site at the time. The physician on-site in the chemotherapy clinic was covering for that primary physician, and as I said before, it is possible for a physician to go into the EMR via Citrix from any remote site via the internet. So the patient presented to the chemotherapy clinic for a pre-chemo assessment, and the way we're structured here, I gave you the date, it was April 5th, 2016. So as you can see, we were 3 years into our electronic medical record. And the patient is assessed by a nurse. What nurse does a standardized pre-chemo assessment, which includes vitals, oxygen saturation, and assessment of toxicities, which is documented in our electronic medical record. And the patient was noted at that time to have some shortness of breath. His O2 sat was low, and he was short of breath on exertion. And so the covering physician decided that the patient was not fit for chemotherapy and for his infusion, which was scheduled 2 days later. So for safety in our clinic, we follow a 2-day model for chemotherapy prescribing, where patients are seen 1 day prior to their chemotherapy infusion appointment to provide for safe delivery of chemotherapy. So in this case, the patient's infusion was scheduled 2 days later, which isn't uncommon. And the physician wanted to delay the chemotherapy and order some diagnostic tests to investigate the shortness of breath and the low O2 sat. So the covering physician decided, though, at that time that he would approve the oral portion of the patient's chemotherapy, in preparation for when the appointment would be next scheduled, and the intent was that this would be convenient for the patient and he would be able to fill his prescription in anticipation of the next infusion. At the time, he did not, the physician did not use the hold function and did not adjust the date for the chemotherapy delivery in the systemic suite when he wanted it to be given. And it's likely that the patient was verbally told on Monday that his chemotherapy would be held, but it's not really clear if that's the case. And there was no note made in the chart that the patient's chemotherapy was on hold. Now, the physician does do a dictation at that time, but it is not usually available until at least a day later when it gets dictated, typed, and e-signed by the physician. So that information would not have been available for anyone else, what his intention was at the time that he saw the patient. So the pre-chemo assessment charts and notes were not available electronically in the dictation. However, the patient pre-chemo assessment by the nurse is available electronically. Now, the primary physician at the remote location was accessing the patient's EMR, and it's thought that he noted that the approval for the oral part of the regimen was approved, and as our thought is that he thought that the physician had neglected or forgot to approve the rest of the chemotherapy order, so seeing part of it approved, he went ahead and approved the rest. It's also in the electronic medical record mosaic, physicians have orders that are assigned to them based on these care plans. So all their pending orders populate into a work list, so they can actually see what patients are scheduled, on what days, what orders they have pending. So since the note by the covering physician was not in the chart, the primary physician and other practitioners wouldn't have known his intention of delaying the treatment. So he saw the order was partially approved, and he approved the rest of the chemotherapy at that time. So the patient called the clinic. So what actually happened is the patient, I think, had received his prescription, got a call from his pharmacy saying, oh, here's your oral chemotherapy drugs to pick up. Maybe caused a bit of confusion. If the patient had been advised at his appointment that he wasn't having treatment, then why is he being asked to pick up his prescription? So he called the clinic and asked the clerical staff, am I having treatment tomorrow? And since all his orders were approved and his appointment was scheduled, there was no indication that the physician wanted to put that on hold. He was advised by the booking clerk that, yep, looks like everything's ready to go, and so the patient presented to the clinic at his previously scheduled time for his treatment. At the time that he presented, he looked well, he didn't have any complaints, and I'd like to share that at the time he was seen, his lab value and parameters were all normal. It was really his clinical symptoms that caused the physician to want to delay his treatment. And at the time that he presented a couple of days later, he didn't have any complaints to the nurse. So he received his parenteral therapy, and it's anticipated that he did take his oral chemotherapy medications because he would have been advised to do so by the nurse as part of his care plan. So subsequently, the patient presented to the emergency department about 7 days after treatment with respiratory symptoms. He was admitted, and he ended up in the intensive care unit. And at that time, the physician raised some concerns about whether or not the toxicities that led to his admission were related to his Velcade chemotherapy. And there was concern that he had had the treatment given that he had these respiratory symptoms. It was unclear when they really reviewed it was whether or not the lung complications were related to the treatment or related to his pre-existing lung comorbidities, but the concern was raised by the ICU physician. The patient passed away, so the incident was investigated. So what we determined when we all gathered together as a group to review this incident was there was a lack of appropriate policies and procedures around using the hold function. So while the hold function is available, it was not consistently used by physicians in the program. There's no alert function to let other users know about any chart notes or communication to let someone know that this chemotherapy was on hold. And in fact, in our center, the only staff member that got notified of a chemotherapy being on hold was the patient booking clerk in order to reschedule it. So we recognized that that was a gap. There was lack of appropriate handover between primary and covering physicians, especially when off-site. There wasn't really clear understanding about who was responsible for what, and we didn't really have any policy on pre-approved orders. So the aftermath, really we looked at it and we thought the hold function should be used and we needed to have a better policy. We needed to ensure that physicians communicated well with what their responsibilities were when they were covering for each other, and we recognized that we needed some pre-approved orders, a standard operating procedure for proceeding with chemotherapy on a day that the patient did not see the physician. So other things that were highlighted was that there was a minimal assessment done on the day of treatment, and this is in fact because usually patients are seen the day prior, so there's not another full assessment done by the nurse. Oncologists are also not informed when patients are admitted to the hospital. There's a lack of information provided to physicians about patients that get admitted, and there was delayed communication between covering and primary physicians. And multiple physicians being able to change and approve orders, and the ability to remote or off-site approve orders through the Citrix application. So there were some recommendations made, particularly also when we did the interview with your group and through the quality and risk management review. So there was the thought that we should consider limiting the ability to remotely approving orders, but we did recognize that this functionality would really be required for continuity of care. Primary physicians should be able to do work from Citrix at home in the evenings, and this is much of the time that they're doing work. Recognizing that an electronic medical record does slow people down, but we needed to be sure that we were ensuring that the understanding about physicians who were responsible for seeing patients a day in clinic covering for others was clear to them. We needed to make sure we captured decisions about making treatment changes directly in the EMR, and that the information would be available to anybody involved in the patient's care, and limiting the practice of leaving orders partially approved, because this is certainly very risky. So in order to sustain high quality practice, we needed to ensure we had some protocols in place to guide practitioners about functions so that there was consistency, and during EMR training, all staff should be explained previously identified safety risks. And we have certainly made some improvements given this incident. So we have developed a chemo hold policy, which really outlines very clearly what the responsibilities are of the physician if they want to place a chemotherapy on hold or delay it. It requires that they choose the date that they want the treatment to be administered, to change the date, to order the correct tests for the next appointment. And we've enhanced the triggers with that chemotherapy hold to include not only the booking clerk, but the pharmacy and the chemotherapy treatment unit as well. Further, we have developed some standard operating procedures for treatment parameters, so it includes when when nurses can proceed with treatment based on patient assessment parameters, including lab work, and we've clearly outlined what those parameters would be for specific regimens and in the general patient population. And we've created a chemotherapy same-day checklist, so regardless of whether or not the patient is seeing a nurse just on day 8 or 15 of a cycle, if it's actually day 1 and they've just recently seen the physician the day before or 2 days prior, that a chemotherapy checklist is gone through, which includes the patient assessment, vital signs, weight, lab parameters, toxicity. So we have implemented that in our program. And I think that's all I have for you. Oh, sorry, I went ahead. I didn't move the slide for that last little bit of my presentation. And we are working on a pharmacy checklist as well, so that the pharmacists will have a specific checklist for every chemotherapy that they prepare for delivery. And that's all for me. Thank you.
Great, thank you, Karen. Technology helps us in so many ways, but this is a reminder that there needs to be appropriate policies and interprofessional communication in place to optimize its use. I'd now like to invite the second speaker, Chief Medical Examiner, to analyze another tragic case that resulted in a patient's death.
Thank you very much. Can everybody hear me?
Yep, you're good.
Okay, perfect. So my name is Matt Bowes, and thank you for inviting me to this forum. This is a really fantastic opportunity. So I'm going to very briefly, I guess, present a case that happens in the community, and I suppose that it's the kind of case that would normally never come to any attention if it didn't come to the attention of medical legal death investigation authorities, so maybe we can chat about the significance of that later. So the person in question is a 38-year-old female with a relatively complex, complex and very poor social kind of milieu, and she has a complex medical history, including what we see here, obesity and hypertension, and she has a very complex psychiatric history, actually. Although interestingly, there are really no strong indications of suicidality in her history. She also has, interestingly, periods of somnambulance, which were relatively well documented, and I'll talk about its significance a little bit later. She was poorly compliant, let's say, with advice that was given to her. So her medications included these, and the significance of that is that these were, well, we'll see later on, but we really didn't find any of this stuff in her toxicology later on. So this individual lived with her mother in a split-level home here in Nova Scotia, and had not actually left the home in the recent memory of her mother. And her routine was always the same. She would really stay up all night smoking and eating, and got up in the very late morning and did it all again. So she was didn't really venture too far outside the house, didn't have any contacts outside the house, and certainly wouldn't have had any contact with illicit drugs or that we know about anyway. So Ms. M.O. died. Her history was that she was last sort of heard rustling around her room at about 11 o'clock at night, which was, again, normal for her. And then when her mother decided that she was up late even for her, she went and knocked on the room door and found that she'd unfortunately collapsed against the door. So 911 was summoned, and there was no resuscitative effort done at the scene because it was clear she was dead at that point. Pretty, thorough scene investigation on the part of my investigators and on the part of police really didn't uncover any suspicious features. So she goes for autopsy, and she's an obese white female, and I'm showing you some of the features here. She has coronary artery disease, cardiomegaly, and on the basis of a really good scene investigation and on no clear trajectory towards suicidality, I certified the death in the morgue that day as due to atherosclerotic and hypertensive heart disease, manner natural. But enough of the circumstances of the case led me to order toxicology, which got back, and to my great surprise, came up with a toxic level of dizipramine, which is a tricyclic antidepressant. What is surprising about this is that she wasn't on this drug, and so the next few days were the objective was to find out how she could have accessed it. So it turns out that actually her mother, I should have done this before, but I did amend the death certificate to reflect the toxicology result, and I gave the manner as undetermined because the mental health history was certainly impressive, but there was really no previous suicide attempts and really no clear trajectory in the investigative record towards suicide. And of course, she did sleepwalk. So the mother was actually taking the dizipramine, and it was her habit, long-standing habit, and I don't know why this is. She liked to take her medications and take them out of the labeled bottle, put them in unlabeled bottles and store the bottles of medication in a candy bowl. Again, I really don't know why people do what they do, but this is what happened. And one of the theories about this death, I suppose you could propose, is that in a period of drowsiness or perhaps sleepwalking, this young woman went out and consumed the desivermine and died of an intoxication. I suppose you could also propose that she may have been suicidal and took this medication deliberately. I don't actually have reasonable grounds to adopt either of those two positions, so as I said before, I gave the manner of death as undetermined, which I think is probably the best thing to do here. So as far as the recommendations from this case go, I don't actually have the power in legislation to make recommendations, but one thing that we are exploring here in Nova Scotia is coming up with durable ways to communicate findings from medical examiner investigations back to health in order to inform better public policy. And these efforts are sort of ongoing. We have a number of informal networks where I feed back information to health, but nothing formal yet. And of course, if any of you have thoughts about how that might occur, I'd welcome the opportunity to know about those. And I think that's all I have.
Great.
Just a quick case.
Thank you, Matt. Yeah, definitely, if anyone has any ideas to share with Dr. Bose, you can use the chat function or the Q&A function. It is definitely an interesting case, and it is a reminder for all healthcare providers that we need to take the time to educate our patients on the safe storage and disposal of medications, both hospital providers and community providers. There's a trade-off from a patient's perspective with having their medications locked up and out of reach and therefore difficult to access when it's needed versus having it too open and easily accessible right next to them. So we really need to have that conversation with our patients and help them come to a solution that's kind of a happy median. So if any participants have stories regarding medication storage conditions that they've witnessed or patient education tips that they've found useful for med storage, please use the comment box and the Q&A box to share. So we'll now get into the observatory for some quick med safety updates. First up is a brief look at a med safety article by Dr. Mike Hamilton of SNP Canada.
Thank you, Ambika. The article that we'll go over this month is from our colleagues down in New Zealand who looked at hospital-related medication safety incidents, and they used a trigger tool methodology. And I chose this paper to remind us that medication-related harm in hospitals continues, unfortunately, despite the work we've done. And it's good for us to have numbers, and it's good for us to be reminded of the work we still need to do. So in this study, a total of 2,659 chart reviews were evaluated, and of those, 751 patients had 923 episodes of medication-related harm. And this sort of approximates 34.7 per 100 admissions of harm and about 42.5 per 1,000 bed days. And interestingly enough, it was a similar group that did a similar study in New Zealand back in 2013 and came up with very similar numbers, roughly the rate of about 30 harm incidents per 100 admissions. And some of their findings are certainly not surprising to any one of us with respect to the medications associated with harm. Again, opioids seems to rise to the top of the class. Anticoagulants and antiplatelets. And if you look at the group of sort of cardiovascular type medications, ACE inhibitors, ARBs, statins, beta blockers, nitrates, calcium channel blockers, diuretics, and anticoagulants, again, they predominate the list. And the researchers also commented that both opioids and anticoagulants or antiplatelets, if you put them together, account for approximately about 40% of the harm occurring in hospitals. So again, this sort of reminds us of the work we have to do, reminds us that some of the medications that people see around the world are the same ones that cause harm here. Although I was a little bit curious is that insulin does not appear on the list out of New Zealand. However, it would and certainly does come across our organization quite frequently as a medication that causes harm.
Okay, thanks, Mike. So next in the observatory is a quick update from Health Canada regarding action taken in response to a med error.
Hélène Perrier, and I'm a pharmacist working here at Health Canada. I'll just move this ahead. Health Canada does have a role in looking at medication incidents, particularly when they might be related to a health product brand name, label, or packaging. We conduct activities both before a drug is out on the market and after it has been approved for use. So pre-market, both pre-market and post-market. Today I'd like to talk to you about just an example of a product name confusion. Name confusion can occur at any step in the drug use process, as we know, including during med-rec when there's actually no physical product present. Sometimes you only have the name and not the bottle. So this was the case in this particular example. Health Canada received a report from a healthcare facility in the province of Quebec, a report of concern due to confusion between these two products. One was BioK Plus and the other was BioK20 Potassium. So, whoops. So you can see here these products are clearly different. BioK Plus is a line of oral lactobacillus containing probiotics. This line is manufactured by a company called BioK Plus International. And these have been on the Canadian market for a number of years, since 1996, and they've been licensed as natural health products since 2009. The other product involved was BioK20 Potassium, which is a generic oral potassium chloride supplement containing 20 milliequivalents of potassium per tablet. This product's been on the market since 2011. It's licensed as a natural health product, and it's manufactured by a company called Biomed Pharma. So as we know, there are a lot of generic potassium supplements, and they often take that naming convention of an abbreviation denoting the manufacturer and K20 or K10, et cetera. So we have JAMP, we have ApoK, we have other products like that. So this potassium supplement product did sort of carry that naming convention. So in the report of concern that we received, it involved two different patients at two different times. In the first case, in both cases, the patient's med-rec list did contain the product BioK20 Potassium as they were taking a potassium supplement. In the first case, the patient's physician on admission saw the BioK20 and assumed it to be the probiotic product. And he did not prescribe it because it was not on the formulary in that particular facility. In the second case, the physician did prescribe BioK20 one tablet daily as per the med-rec list, but in this case, it was the hospital pharmacist who saw it and assumed that it was probiotic. The BioK products in the province of Quebec are quite popular, I believe, and so they were very well known, and it seemed like both healthcare professionals assumed that that was what was being prescribed. So they sent a note to the ward saying this is non-formulary and didn't dispense it. So what ended up happening was that both patients missed an unknown number of doses of potassium. So they obviously could have been at risk for hypokalemia, and this kind of product confusion, if they had gotten, for example, the probiotic instead of potassium, they could experience hypokalemia, or if they got potassium when they were supposed to be getting probiotics, then they would be at risk for hyperkalemia. And as we know, both of those conditions can be asymptomatic until serious cardiac events occur. So we at Health Canada communicated with the Biomed Pharma company, and we requested them to change the name of their product because the BioK probiotic had been on the market for a much longer time. So the second to market is the one that we requested to change their name. We also communicated this case to healthcare professionals, and it was published in Health Canada's Health Product Info Watch, the former CARN, now Health Product Info Watch, in November of 2015, and you can find that on Health Canada's website. So in conclusion, I'd just like to note that if a medication error occurs and when you're reporting it, you feel that the name, the label, or the package could have been involved or could be a contributing factor to the error, it's always good to note that on the report when you report to ISMP or to wherever you would be reporting it to. And that's all I have to say. Thank you.
Great. Thank you, Helen. Thanks for that action update from Health Canada. Mike and I will now briefly go over a couple ISMP Canada bulletins from this year. It'll be a great refresher for those who've already read them, and we'll provide highlights for those who may not have had a chance to do so yet.
So thank you, Ambika. So our first bulletin we'll go over is from February of this year, and again is sort of the provenance is from one of our coroners associations where we do get a good number of cases that we feel are important because unfortunately do lead to death, but there's often a lot of learning to be done. And this one in particular is about a young adult on thyroid replacement therapy, but unfortunately did not have a level for approximately 3 years. And the level of 3 years ago did suggest that she was somewhat over-replaced and had some exhibition of hyperthyroidism. There was no documentation to show that she'd been followed up and rather had been renewing prescriptions via fax or just via phone between the pharmacy and her healthcare provider. And this certainly happens quite frequently with fax machines, and I think in the future as we develop electronic prescribing systems as well as instant pharmacist prescriber messaging, this is something that may occur. So I think there's some valuable lessons in here. Particularly for chronic conditions such as thyroid disease or other drugs that may require some type of level or monitoring, such as warfarin or anti-epileptics. And some of the recommendations arising from this analysis and bulletin are really to develop standardized processes for making sure people do get followed up, making sure that levels of medications are taken at appropriate times, and now, particularly in Ontario, that practitioners or prescribers do have access to laboratory levels ordered by other physicians or as part of the large Ontario laboratory database. That even might be easier. As well, I think patients do play a role here. An important takeaway is to educate patients with chronic medical conditions that you do need to have your levels checked from time to time, and it's sort of not best practice to just go in and ask for a repeat prescription over and over again, and that there's reasons that we do need to follow up with your levels. As well, from a pharmacist side, ensure that that it's an appropriate ensure that it's appropriate practice to simply request a refill from the prescriber's office, and to make sure that the person in question has had a level done from time to time. And our next bulletin is, I believe, our most recent one from the end of September. And this is sort of explaining a visual learning tool that SNP Canada, along with a number of partners, in particular the University of Toronto and Physicians for Responsible Opioid Prescribing out of the U.S., put together to help people, prescribers, pharmacists included, to better understand the concept of morphine equivalence. Our partners at the U of T in particular noted that some people, prescribers, physicians, just didn't get the concept or had difficulty appreciating what exactly morphine equivalence was, and therefore what exactly the association between the risk and the level of drug or the level of prescribing was. So this led to the development of a communication and risk assessment tool. And really our hope for this is that prescribers will use this to really refresh themselves about the relationship of the risk and to really understand that, in all honesty, it doesn't take much medication to really get yourself above suggested level or above the morphine equivalent level of 90 as suggested by the guidelines. And so we also would encourage pharmacists to use this as a refreshing tool too, and all practitioners to use this with patients in order to give them a better understanding of some of the concerns with higher prescribing or higher levels of prescribing of opioids. And this is also available in French as well from our website, and is sort of freely available and has been recently refreshed in order to ensure compliance or ensure concordance with the 2017 guidelines.
Thanks, Mike. So for the safemedicationuse.ca, that's our consumer-based website, and when we do newsletters for the consumers, we often do have a sidebar with tips for practitioners in the SNP Canada safety bulletins that are targeted to practitioners, so you can keep an eye out for those. SafeMedUse.ca received a report of long-term adverse effects resulting from a drug interaction between citalopram and tramadol, and the interaction caused psychological and physical symptoms. The patient was unable to care for herself even after the interaction had been addressed. And so the following tips for practitioners are presented to support patients' efforts to prevent drug interactions and minimize the risk of harm. So it's important to recommend to patients that they use one pharmacy for all their prescription and non-prescription needs, because using a single pharmacy will support the detection of drug interactions. To also consider a drug interaction as a possible cause of a patient's new symptoms or sudden change in health, and then investigate that accordingly. To, of course, conduct regular medication reviews, including non-prescription and natural health products with the patient to identify potential drug interactions, and to help the patients keep their medication list up to date so that that can be shared with all healthcare providers. So the second article targeted to consumers, it was a report received from a patient who brought a prescription for a corticosteroid cream to treat a skin condition. However, when he returned to the pharmacy to pick up the prescription, the pharmacist began to explain how to take corticosteroid tablets. Because the consumer had not expected to receive tablets, he questioned the instructions. The pharmacist then realized that a mistake had been made when reading the prescription and then took steps to correct it. A conversation with the patient about his or her new medication will not only provide the patient with important clinical information, but it also gives the healthcare provider the opportunity for one last check before the patient takes the medication home. So some tips for practitioners are to offer medication counseling to all patients before releasing any prescription medication, including refills, and take the time to highlight key points about how to take the medication, side effects to look out for, and any relevant medication safety issues. And always ask them if they have any questions. use the show and tell technique when counseling. So you want to open the medication vial so the patient knows what the medication looks like, and point out instructions on the label. This will also allow a final visual verification step, so you can ensure that the patient is leaving the pharmacy with the correct medication. So just to start off our discussion, we appreciate all the great information shared by our speakers today, and we'll now look at the Q&A box or the chat box, and we'll direct comments to the speakers so that they can elaborate.
All right, thank you, Ambika. We'll start, and this one is directed towards the remote prescribing of chemotherapy case. Question is, you've highlighted an important vulnerability in electronic medical records, and that's the capacity for people, for a number of people, to have access to and manipulate the data and manipulate the orders. You've outlined a number of important interventions here. It sounds like in this case, though, the patient did have an understanding that there was supposed to be a hold on the treatment. Is there an ability to leverage that role or to leverage that patient for safety in these cases, like maybe some type of information card, or instead of a prescription, an anti-prescription or a hold prescription that they can show to the next person in the line in their health care?
Karen, are you there? Oh.
From the physician's perspective, when we reviewed the incident, he did say he had indicated to the patient, you won't be having treatment this week. I'm going to do some investigations. And the confusion, I think, lied in the fact that he provided the oral prescription, and he did that after the fact. So he didn't actually share with the patient, I'll give you the oral medications anyways, but wait to hear from us about when your next treatment is. So when the patient got called by his clerk and pharmacy that your prescriptions are ready, then I think what he thought was, oh, well, did I misunderstand what the physician intended? And when the patient did phone to check, so obviously he phoned because he was confused about the two different messages he'd received. And what was impacted is the fact that the rest of the order had been approved remotely, so it looked to everybody like it was approved. So had the physician remotely not approved the systemic part, that would have been clear to the rest of the team that, oh, wait a minute, this doesn't look right, and they would have probably asked the question of the physician on site, what did you intend here, because the patient has received the prescription, not everything is approved, and they're calling to ask. So our concern was the remote prescription was, implicated in the fact that this happened, and had that not been done, if the patient's confused and they call, if things are not ordered or approved, it's very clear to the rest of the team that things aren't ready to go. But I do appreciate that, yeah, it might be helpful to have the patient have some role in understanding the plan of care. Does that help, or?
Thank you. And I have a second question for you as well that came up. You've talked about sort of the chemotherapy process, or the chemotherapy ordering process through sort of Mosaic or Citrix. Are there other areas in the hospital that use a similar sort of process, whether it's through CPOE or other sorts of electronic medical record that may be as well vulnerable to this type of incident?
Yeah, so I'm not entirely sure because we're in, I didn't identify myself, but we are in Thunder Bay, at Thunder Bay Regional in Northern Ontario, and our cancer program is affiliated with Thunder Bay Regional Hospital, and some of you may know that years ago we were all part of Cancer Care Ontario, and then we amalgamated with host hospitals. So we're kind of a department of the hospital. So we do have Meditech for some things, and the hospital EMR is Meditech, and they are not fully electronic, and I don't believe they have CPOE. physicians still write orders on paper charts. Now, I do know that in the last number of months, they have been implementing some order sets. So I think for hip replacement, COPD, CHF, and I believe some of those order sets do include medications. So, but I'm sorry, I don't have enough information to answer that question. But from my knowledge, I think we are the only department in the hospital that has true CPOE for patients in the hospital.
Thanks, Karen. So we do have some stories, not necessarily questions, but related to the med storage case. So I'll just read those out, and I'll see if any questions come in during that time. So one participant said, I often see patients presenting to my clinic bringing in their multiple medications all mixed together in one container, and these are home prescriptions filled by a community pharmacy. So she's not sure what education is done in the community, and that she's never personally received any instruction on medication storage from a community pharmacy. So that's an important gap that we can all try to address. A second comment related to storage. My 2-year-old son accessed my prescription medications that were stored in a compliance aid that I put up on the counter, which I thought was out of reach for him. Fortunately, he didn't swallow any pills, but I learned an important lesson that day, and now I keep my meds in a combination locked tackle box.
And I'll speak here a bit from personal experience, because I am a prescriber, and I see patients bringing in their medicines from time to time, and in all honesty, a lot of them do look like candy, or candy looks like medication. So I can understand that people get this confused or mixed up, particularly when, as Matt Bowe suggested, the storage conditions are not ideal. Another sort of candy-related thought that I had is when prescribing medications, or liquid medications in particular, you do want them to taste good enough to take, or that they're not spit out, particularly by kids, but the trade-off is that they taste too good and people ask for them. And we do have kids, particularly when I attend the walk-in clinic, that come in and the first words out of their mouth are, can I get the banana-flavored medicine? So there's a trade-off between being able to take the medication and liking it too much, and that's certainly true for the antibiotics, but also for a lot of the medicine that we give to children, which is in liquid form. And this question is for Health Canada, Helene Perrier, about the look-alike, sound-alike case. And just asking for any comments about similar drug names or brand names or trade names that have a number of line extensions. Sort of what sorts of problems do you see, and what sorts of solutions do you have, or is it on a case-by-case basis?
That's a really good question. As of 2015 for prescription drugs, and as of very recently in June 2017 for non-prescription drugs, there is a new requirement for a fairly thorough brand name assessment before a product is approved, before a brand name is approved, I should say. And we work closely with the pre-market reviewers to try and identify cases where this might be a problem, and to try and look at the labels to ensure that these products can be differentiated sufficiently through different design elements. There's a list of criteria that they use. They have a checklist to try and minimize the misleading aspects of a drug name, and to try and, the problem with over-the-counter brands, we all know that there's a lot of line extensions and umbrella branding, and hopefully with this new requirement as of June 2017 for more close name review before a product is approved, that we'll be able to minimize or catch some of those problems.
Great, thank you, Helen. So I just have one more story that came up. My 90-year-old mother-in-law was given antibiotic in a child-proof container without asking. Her regular pharmacy, who provides her blister packs, was closed. So when I followed up with her 24 hours later, she hadn't taken any as she was not able to open it. So that's really another important learning for us in reaching that happy median where we want it to be safe, so it's not accessible by those who shouldn't have it, but it does need to be easily accessible by those who need to use it. So thank you again to all our speakers and to all the participants who tuned in today. We want everyone to be part of the Med Safety Exchange, so whether it's an incident analysis or a Med Safety initiative, please email me to share the learning. Also, don't forget to fill out the poll that's now available on your screen. We want to hear from you because you're part of our pilot run, and we want to be sure that we're meeting your med safety needs and making the webinar most relevant to you. The registration for next month's webinar on Wednesday, November 8th, so that's just 3 weeks away, is now open, so you can head over to the site and register for it. And thank you again. I hope you all have a wonderful day.